Good morning. We are ready to begin our webinar. So I'd like to turn it over to Nancy Young, who is the Director of the National Center on Substance Abuse and Child Welfare.
Thank you very much, Han, and thank you to all of the participants who are on the webinar today. We're excited to share this information with you. We've been pleased to see the response from so many from around the country with their interest in this topic. Just to let you know that we at the National Center on Substance Abuse and Child Welfare, under the guidance of Sharon Amatetti, who is our project officer from the Substance Abuse and Mental Health Services Administration, and Elaine Stett from the Administration of Children, Youth, and Families, have convened over the last year a group of about 40 professionals that represent child welfare, substance abuse treatment, healthcare professionals, the dependency court involved with child abuse and neglect, to develop guidance about this issue of opioid use in pregnancy. And along that same path, we have developed a case study of what they have put together in Vermont, in Chittenden County, which is Burlington, Vermont, and then expanded to some of the other communities in Vermont, referred to as the Children and Recovering Mothers Collaborative. And we're joined today from Sally Borden and Karen Shea from Vermont. Sally's the Executive Director of the Kids Safe Collaborative and serves as the facilitator for the CHARM Collaborative. And Karen Shea is the Operations and Child Protection Director for the Vermont Department of Children and Family in the Family Services Division. So thank you very much, Sally and Karen, for sharing your knowledge with us today. After I do some beginning comments on the overview of the issue, talk a bit about medication-assisted treatment and some of those policy and practice issues that we're hearing at the National Center as we get technical assistance requests. And then I will turn it over to Sally and then Karen to describe what they've put together in their community and how they team for success for this set of mothers and children and their families. As I mentioned, our project officers, the National Center is a program of the Substance Abuse and Mental Health Services Administration and the Administration on Children, Youth, and Families. If you haven't visited our website, I would encourage you to do so. We have that contact information at the end of this so that you can easily access the website. And you may have noticed on the front page, as we were waiting to launch the webinar, that the materials from today's session will be posted on the National Center website, as well as will be emailed out to all of the registrants when the webinar concludes. So you'll have a copy of the PowerPoint, you'll have the case study from the CHARM Collaborative, and other materials that we're sending out to all of the registrants. So with that, let me get started. When we look at what's happening in opioid use in the country, if you think about three different ways that you can measure what's going on. One, initiates, so how many new people are beginning to use an opioid. And you see in the data that from about 0.06 that would have been in the Survey in Drug Use of Health as new initiates, people who are beginning to use heroin in 2002 to 2004 when the data were analyzed between that time period, compared to 0.10% now, more recently, 2009 to 2011. So as you can see, overall, it's a small percentage, but it has increased pretty dramatically, especially when you look at the data on those that meet criteria for substance dependence. A 50% increase in those that are 12 or older who are dependent on heroin, and you see the numbers of 2011, about 370,000 people. And then very disturbing, as we know in the media and we hear from areas of the country that are being increasingly impacted by overdose deaths, that those deaths since 1999 have had a 500% increase in women using opioid pain relievers and overdosing. And again, very disturbing fact that overdose deaths surpassed motor vehicle accidents as the leading cause of death in the country. And those of us that grew up before seatbelts were required in cars, you can imagine that this is an alarming statistic when you realize that what we have done to reduce motor vehicle deaths means in part that has contributed to the reduction in those deaths while we have an increase still in the opioid overdoses. So when we look at some of the information that we hear and get questions about of the non-medical use of prescription drugs, and is there an association between those non-medical use of pain relievers and the initiation of heroin use? I think anecdotally and in the media, that's what we're reading, that's what we're hearing, that as the states have had better controls on the prescription drugs for pain relievers, that individuals that find that they frankly are priced out of that market or no longer have access to that there's an initiation of heroin. And in fact, when you look at those that have begun using heroin, that they were 19 times more likely to have reported non-medical use of pain relievers prior to the initiation of heroin. So with those increases in use, we would expect, I guess, that we would also find data that says that during pregnancy for women, that prescription opioid abuse has increased. Now, these are data that are drawn from what's called the treatment episode data set. Those are the treatment admissions that are reported by states to SAMHSA for all treatment admissions that have public funding in the country. And you see the increase in trend when you look at the blue line among pregnant women for admissions for any prescription opioid use. And again, if you look at overall all admissions, it's not the majority, but definitely increasing, particularly if you look at pregnant treatment admissions as prescription opioids as the primary substance of abuse. So we can see that the overall proportion of pregnant women among treatment admissions has not significantly increased from 92 to 2012, and yet the type of drug that they're reporting as their primary substance has changed over that decade. We also know that there's a difference, or there, I think we could say, used to be a difference in the treatment admissions that were being reported across the country. And you see again from 1992 to 2012 that the blue, beginning in the Midwest and really the East Coast, treatment admissions increasingly being prescription opioid use. This is specifically among pregnant women, women that were pregnant at admission, and then moving from that blue into yellow, meaning that of those that were pregnant at admission reporting prescription opioid use, the yellow, the red, increasing concentrations, to now across the country, across each of the states, of pregnant women admitted to treatment, 25% of those admissions are reporting prescription opioid use. With that, we also know that there is a unique pattern for babies that is unique to opioids, referred to as neonatal abstinence syndrome, that occurs when babies are exposed to opioids during pregnancy. We know that there's a lot of research on this population, and I'm going to go through a little bit of that right now to describe neonatal abstinence syndrome that usually appears within at least the first week and a half, sometimes, as it says, 1 to 3 days, or it can be a little bit longer. So you may be getting, if you're in child welfare, reports for babies that have already gone home potentially that begin to have symptoms, and particularly if you are in pediatric care, that you may have this coming in that is a week or so after birth. You see the kinds of symptoms that may appear. We also know that that onset is somewhat related to the characteristics of the drugs used by mom and the time of last dose. So we're going to talk a little bit about what that looks like in terms of the characteristics of pregnant women, but want to emphasize that the most opioid-exposed babies are exposed to multiple substances, and there's long-term research about some of the other substances as well as those that are exposed to opioids. We also know that there's a great deal of variability about the babies that actually exhibit symptoms of NAS, or neonatal abstinence syndrome, with a pretty wide range of those that exhibit symptoms, and that medication is required in really only about half of those cases. Now, I think one of the encouraging things that we'll hear Sally and Karen talk about in terms of what they find in Vermont is that medications are required in a much smaller percentage of the women that they are involved with, based on some of the interventions that they're putting in place during pregnancy. So we're excited about that. We also know that there are many studies about the long-term impact, and if you look just at the cognitive development of babies that have gone through NAS just after birth, that those are within normal range when looked at in this preschool period up to age 5. There are old studies of heroin exposure from the 70s and 80s that have tracked babies even a longer period of time. And what we know about that is that the environmental context of the family characteristics, did the mom have prenatal care, what other substances were involved during the time that she was pregnant, and other medical and psychosocial factors that have a significant impact on those longer-term outcomes. So it's, as you know, it's difficult to tease apart a particular substance, but we do know for most substances, including opioids, the other things that are going on in the child's life may have more of an impact than what has gone on during the prenatal period. When we look at the estimated number of infants that are affected by prenatal exposure, again, pointing out that where illicit drugs come into play, that gray bar, includes heroin and the non-medical use of prescription drugs, but that the number of babies that are exposed to tobacco and alcohol are much larger. And we also know some of the medical complications and long-term outcomes from tobacco and alcohol. If you aren't familiar with those, if you send an email to the National Center, info@National Center, we'd be happy to send you some of the information about prenatal exposure that we have available. And clearly that binge drinking and heavy drinking, which can result in implications for the child of fetal alcohol syndrome, alcohol-related neurodevelopmental effects, and that percentage that we have for estimates of those effects in infants compared to those that have this sort of immediate after birth neonatal abstinence syndrome, meaning that the FAS and ARND, FASD, all of those different acronyms that point to prenatal exposure to alcohol, particularly binge drinking and heavy drinking. A recent study from that published in JAMA, the Journal of American Medical Association, that looked at neonatal abstinence syndrome and healthcare expenditures over the period of 2000 to 2009, you see that the incidence of NAS, neonatal abstinence syndrome, has increased dramatically, while still the rate is lower than some of the other substances of abuse during pregnancy. It's important for us to pay attention to this particular set of infants, particularly since there are well-developed studies and knowledge about their treatment and the ways in which infants and their moms and their families can be assisted. When we look at the different populations of women that can give birth to infants with NAS, recall the slide about the variability of when NAS is actually materializes, when it gets diagnosed. And we think it's important to pay attention to which population of women we're talking about. Babies may experience neonatal abstinence syndrome when their mother has been treated for chronic pain or other medical conditions, who's been maintained on medications. There's a difference between that population, we think, in the kinds of interventions compared to a mom who's actively abusing or is dependent on heroin, for example, those that may be misusing their own prescribed medications, those that may be misusing non-prescribed medications, meaning they're purchasing or they're using their peers, or they're getting medications that are not being prescribed for them and misusing those pain relievers or with an opioid base. And then the difference between that and a woman who is in recovery from opioid addiction and is maintained on methadone or buprenorphine, who's receiving medication-assisted treatment, who is under the care of a physician and taking medications to manage her opioid addiction during pregnancy. And we have found in child welfare services over the decades that as trends in changes in particular drugs come into play, that sometimes there's a tendency to group all of families together as one kind of substance user and not really differentiate who are we talking about. Are there differences in the population? And we think what's key is differences in the interventions. Knowing that there are differences in pregnant moms and the kinds of substances that you may see a similar effect for the baby, but really need to understand what the differences are between the kinds of populations that you're being called about when you have a report. So let me turn to a little bit of information about medication-assisted treatment in particular and opioids during pregnancy. What happens when mom is not on MAT, medication-assisted treatment, and she's using a substance, either heroin or non-medical use of prescription drugs? What the baby is experiencing is similar to the mom's experience, with a high and a low of that exposure. And one of the goals of MAT, medication-assisted treatment during pregnancy, is to even that out for the baby, to make sure for the baby that that environment is as stable as can be, and we're avoiding that that high and that low from the medication or from the illicit substance that mom may be using. So about that medication-assisted treatment, this is the list of the principles of effective drug addiction treatment from the National Institute on Drug Abuse, and just highlighting that medications are an important element of treatment for many patients, especially when combined with counseling and other behavioral therapies. When we look at medication-assisted treatment for opioid dependence as part of a comprehensive treatment program, these kinds of outcomes have been demonstrated for many years, for decades of research, that we understand that the complications during pregnancy, that there is a decrease in illicit opioid use. All of those kinds of benefits happen when we're able to intervene with mom and establish her on medication-assisted treatment. I'm not going to go through the detail of this chart. Again, you'll have this PowerPoint. If you have questions about this, please do email us. We'll be happy to respond to this kind of information and point you to the research behind this. But the kinds of medications that can be used to treat opioid dependency, somewhat different from methadone, buprenorphine, or naltrexone, and important to know about opioid treatment programs that are certified by SAMHSA, that are the dispensers, if you will, of methadone, versus physicians and psychiatrists who are granted waivers in order to prescribe buprenorphine and Subutex or Suboxone for people with opioid dependency. And again, more information is available on that so that you have a better understanding of what an opioid treatment program is. But important to know that each medication varies in its ability to reduce withdrawal symptoms and reduce drug craving, which is an important component during pregnancy so that the pregnant mom doesn't return to the illicit heroin use or going back to that up and down cycle, if you will. It's important to note that doctors need to determine the appropriate type of medication, the dosage and duration based on each person's biology, their addiction history and severity, the life circumstances and needs. I probably don't need to mention for the number of times that we hear that other folks are making determinations about dosage or making determinations about having mom decrease her dose level versus the medical professional who is treating her. There's also important information about what you can expect from an opioid treatment program, that there is a medical director who's licensed and has experience in addiction medicine, who's responsible for the monitoring and supervising the medical services, that those OTPs, or opioid treatment programs, have requirements that there be medical, counseling, vocational, educational, other assessment and treatment services, and that special services are in place for pregnant patients, including the priority access and provision of referral for prenatal care and gender-specific services when a pregnant mom requests treatment for opioid addiction. It's important, again, to know that ACOG, the American College of Obstetrics and Gynecologists, has issued an opinion about the standard of care for pregnant women with opioid dependence. This is a resource, again, that you can obtain on our website so that you have that information about what ACOG says about opioid dependence during pregnancy and appropriate treatment. There have also been now studies about buprenorphine during pregnancy and the kinds of outcomes and the issues related to breastfeeding recommendations between methadone and buprenorphine. Also important to know that there are special considerations for women who are opioid dependent and treated with medication-assisted treatment to ensure appropriate pain management during birth, during the postpartum period, particularly related to managing her risk of relapse. And we think an important statement that NAS is an expected and treatable condition that follows prenatal exposure to opioids. Would all of us like to say that this would never happen for a child? Yes, if we could say that all children in our country are raised in families in which alcohol and drug dependency does not affect their well-being, that would certainly be our preference. But understanding the the prenatal environment for children and the postnatal kinds of treatment options that are available is important, and according to ACOG, a standard of treatment. We also want to highlight what those implications are when child welfare gets a report from a hospital about a prenatally exposed infant. The Child Abuse Prevention and Treatment Act is clear about appropriate referrals are to be made to Child Protective Services for child protection and appropriate services to ensure that the infant's needs are being met. It's important to recognize that that does not immediately say that that should be construed or to establish a definition under the federal law of what constitutes child abuse or neglect, but that there is a requirement when these infants are identified that there is a plan of safe care for the infant who's born and identified as being affected by illegal substance abuse or withdrawal or fetal alcohol spectrum. That's the important part, we think. Both the reporting, understanding how many infants that you are intervening with, and ensuring that there is a plan of safe care for that infant and their family. So if all of those things are standards of care and there's knowledge about how to manage infants with neonatal abstinence syndrome, why are there so many barriers to just implementing this in practice? We found in this work group that has been advising us over the past year that the variation in response in child welfare can be state to state, county to county, and sometimes worker to worker based on their ability to collaborate with their treatment agencies about their own knowledge about practice gaps and how they get women into treatment and to get neonatologists that understand the management with NAS. All of those conditions about ensuring that the treatment resource is there for women and their children, and the medication availability in some regions of our country in which that's not available to pregnant women at the kinds of numbers that we should be providing. So those barriers to best practices, as we have worked with this group and are pleased that there will be guidance coming out to states and communities about developing this collaborative approach so that women with opioid use are identified during pregnancy, that they are engaged in prenatal care, medical care, substance abuse treatment, and other needed services, and that a case plan and plan of safe care for the mother and the baby is developed. And ideally, that would happen during the prenatal period with a partnership with our OBGYNs, and to ensure that the number of babies that are identified at birth and can often be treated as a crisis, that there is an emergency response and, if you will, a flurry of activity to ensure that babies have the safe care and the protection that they need. We're so happy to be able to present what the CHARM Collaborative in Vermont has done so that they're reducing those number of crises at birth for women, for babies, and for their system, so that there is a plan in place that appropriately addresses the safety factors for babies, the treatment needs of their mothers and their families, and helping to ensure when possible that babies and moms are able to bond appropriately through being able to stay in the mother's custody. With that, I will turn things over at this point to Sally. Thank you again, Sally, for the work that you have done in Vermont for over, I think, a decade now to develop this knowledge, and thank you for your willingness to share that with the rest of the country. Sally?
Thank you very much, Nancy. And our group, the CHARM Children and Recovering Mothers Collaborative, has come together in a unique way, I would say, and I'm really delighted to be able to share that with you today and to have this work featured by the National Center for Substance Abuse and Child Welfare. So CHARM is a multidisciplinary group, and we serve pregnant women with opiate addiction and their infants. And we are not one program exactly. It's a group of services that come together to provide a continuum of care for pregnant and postpartum women with opiate addiction and their infants. And our focus is, we really have an overarching goal that we all share and come together kind of under this idea that the best way to improve the health and safety outcomes of babies is to support their moms and to make sure that they get the appropriate services so that they can deliver a healthy and safe baby. And the ways, the objectives of our team, the things that we focus on as a team are engaging women in early prenatal care as early in the pregnancy as possible. We focus on reducing the cravings and the withdrawal symptoms that Nancy just described using medication-assisted treatment, engaging the women and, when possible, though not always possible, their partners in substance abuse counseling, and providing social support and basic needs referrals for the mom and, again, if possible, for the family. So those are the main areas of focus for our team. But again, we're really focused overall on improving the health and safety outcomes of the babies. So who's involved in CHARM? What is CHARM exactly? We have a number of key partners, starting, I think, most importantly with our medical providers who are based at our local hospital, Fletcher Allen Healthcare, and Vermont Children's Hospital, the high-risk obstetrics clinic being part of Fletcher Allen Healthcare, our neonatologist and neonatal medical follow-up clinic being Vermont Children's Hospital, along with pediatric social work. Then KidSafe Collaborative, that's my role, and my job is convening and facilitating the team, getting everybody together and making sure that everything works smoothly. The substance abuse treatment provider key agency in our community is called Howard Center, and they are the provider of medicated-assisted treatment and also substance abuse treatment services. We have a unique and wonderful program in our community called LUND, and LUND provides both residential services for pregnant moms and their babies, and parenting support and substance abuse treatment and outpatient treatment as well. And that's gender-specific treatment. The VNA provides home visiting services, which are obviously very key to pregnant and postpartum women and their young children. And then we have a number of key partners who are from the state-based organizations, and you'll be hearing them a little bit from Karen Shea from our Department for Children and Families. We also have participation from our Department of Corrections. Our health, alcohol, and drug abuse programs has been obviously a key partner, and in terms of a number of different services, and they are the State Opioid Authority. Health, maternal and child health is, again, another key partner, and specifically the WIC clinic and the connection between our community home visiting services and our Medicaid authority, the Department of Healthcare Access. I want to go back for just a moment and give you a little bit of the history because I think it helps to know a little bit about how we got started. And our team really developed organically. It started when there was no treatment available, and a pregnant woman, showed up who had a heroin addiction. And so our addiction specialist physician requested a waiver from the Opioid Treatment Authority, our health department alcohol and drug abuse programs. And that kind of one-by-one approach is how we really started. And then that physician connected with an obstetrician working with our high-risk patients and a neonatologist, and it made sense to figure out that by working together we could provide better services for these patients and better coordination is going to result in better care. And it might seem really basic, but I know that for those of you who are kind of on the ground delivering services, you know that it works better if you can coordinate the services and connect with the various service providers and medical providers involved. And so that's really how our collaborative came about, by these folks coming together to try and provide better care for the small number of patients that they were serving initially, and then that grew. Our first methadone clinic opened, and fast forwarding, I think, to now, the neonatal portion of this project has delivered close to 1,200 babies. We have about 120 infants born annually to mothers on opioids, and so over the years this approach has grown. But again, it just really started as a coming together to work collaboratively. We, in those early days, then figured out, gee, this is going to work better if we bring the other key players together. And so bringing child welfare in, bringing the community-based service providers, the State Department of Health, all of those services were key. There were clearly initial challenges, not that this collaborative idea was easy. We spent a few years trying to work out a memorandum of understanding, which we'll come to later. But those were the kinds of challenges that we faced. There were different treatment philosophies. Not everyone agreed that that women with a history of opiate dependence should ever be able to parent their children, for example. Should we share information with child welfare? What's their response going to be? How can we share this information? Isn't it all privileged information? And how are we going to overcome those barriers? So there were a lot of challenges that we faced initially. And as I go through this, I'll talk a little bit about how we overcame most of those, some of those, and how we continue to work on some of those challenges. So how it kind of works, what are we talking about? Well, our team, each of the members of the team, provide their services individually, so the prenatal care, the neonatology, and so on. But as a team, the collaboration piece of it is that we meet monthly. We all come together monthly, and we review a list of current cases. And we go over all the new pregnant patients, who is new to our list, and then much more importantly, who are the patients who are due in the upcoming month before we meet again. And we focus on those who are the highest risk prenatal patients, and those who are struggling in their treatment, those who have not been coming to prenatal care. And then we also go over who are the new babies that have recently been born, and how are those moms doing, how are those babies doing, and who are the highest risk postpartum patients and their babies. And again, we are looking at coming together and sharing this information because over the years we've really agreed upon a overarching shared philosophy that improving the care and supports for the moms is the most important factor in making sure that the babies are healthy and safe. So we focus on that. So the prenatal care, so pregnant mom comes in, and the prenatal care focuses on, first of all, a comprehensive assessment of opiate dependence. So first we're looking at is the mom, opiate dependent, and is she in need of medication-assisted treatment, as Dr. Young described? Is she pregnant? I guess that is also one of the, the first things that we're looking at. And then setting up enhanced prenatal care, so a regular schedule of prenatal care, prenatal visits, frequent prenatal visits, and those include urine drug tests. Substance abuse treatment is required for all women receiving medicated-assisted treatment, so they are also receiving counseling, and that's most recently been further supported by our Department of Health Alcohol and Drug Abuse programs that has set up substance abuse care coordinators and treatment providers within various MAT provider settings. And perhaps the most unique and important part of this is a visit to our neonatologist or the neonatal clinic for a prenatal consultation. And the most important part of that is easing the pregnant woman's fears about delivering a baby who's been exposed to opiates. There's often, and as you are well aware, shame involved, fear involved. She may have come into treatment because she wants what's best for her baby. That may be what motivated her to come into treatment. And she's worried about, is her baby going to be born healthy? Is the baby going to need treatment? And so that neonatal consultation is such an important step in establishing initial trust and helping to alleviate her fears. And one of the important parts of that process is that over the years, our neonatology clinic has developed a notebook that was developed by moms who have been through this process, who said, this is what moms in this situation need to know. Pregnant women with a history of opiate dependence need to know that their baby's going to be okay. And so there are stories in there from moms telling their own stories. And then there's also key information that they're going to need. And so every woman that comes in for that neonatal consult prenatally will get a copy of that Our Care notebook. So some of the things that we're looking at when we come together on that monthly basis and we're talking about our prenatal patients, the things that we're looking at as a collaborative, and all of the team members are weighing in on this, are what are the positives, and then what are the things we're concerned about. And we've identified over the years the key things that are going to be indicators about how a woman's doing in her pregnancy and the prospects for her having a safe and healthy delivery. So is she attending her prenatal appointments? That might seem really basic, but it's so important. And research has shown us that early engagement and regular attendance at prenatal appointments can have a positive outcome on the birth weight of the baby and is critical to the overall health of the baby. Certainly participation in substance abuse counseling and in their medicated assisted treatment. So if they're not coming in for their medicated assisted treatment or they're not complying with the requirements of that, we know that that's an indicator of a problem. And we look at progress in recovery. We look at what else is going on in the home environment that might be an indicator of concern or a positive. And with that, of course, we're brainstorming, how to re-engage a woman in coming in for her prenatal appointment if she's been missing. We set up a plan for contacting her, who's had the most recent contact and can reach out to her, and set up a plan for making sure that we do our best to re-engage that woman in participation in the project. If she's continuing to use non-prescribed medication in her third trimester, we talk about making a report to child welfare, and Karen will describe child welfare's involvement prior to the anticipated due date to first of all start working on that plan of safe care, but also, as Nancy said, we are really able to hopefully better identify those who are struggling early and have been able to reduce the crisis responses at birth. And that's not to say that there never are, but we have a better idea also of who is not doing well and can anticipate that prior to the birth of the child. So when we are talking about the birth, the time of birth, really, again, the most remarkable part of this project, I think, has been the ability to engage child welfare before delivery as a team and being able to assess if a child isn't doing well, and if caring for the baby is a concern, making sure that information is shared and that child welfare is alerted to that prior to the anticipated due date so that you don't have that crisis response upon delivery, that you can plan for that. Certainly the neonatal abstinence syndrome assessment and treatment is a very important part of the birth and postnatal care. And that has been done, it's done very, very carefully and a nuanced approach that involves the moms or parents in the scoring. And our neonatal follow-up clinic has, I think, developed a tremendous amount of expertise in doing this over the years. And through that process has through very careful monitoring the babies and controlling the use and engaging the mom's use during pregnancy and engaging them in early prenatal care, all of those factors, we have found here that there are significantly lower rates of babies requiring treatment than the national average. Dr. Johnson, our neonatologist, has indicated our rate at the primary hospital in our community ranges around 20% at this point, and that, again, is significantly lower than the national rates that Dr. Young cited. And we're very excited about the prospects for that. I think certainly it's something that we're paying attention to on an ongoing basis. We have our neonatal follow-up clinic then provides an intense level of support for the moms and the babies in following up their NAS assessment in the hospital. If they do require treatment, the approach here, again, is a little bit different than most in that the infants are prescribed a very low dose of methadone, and that is able to be administered on an outpatient basis. So our neonatal follow-up clinic trains the parents or caregivers on administering that, and then the wean from that dose is carefully monitored over time with very regular visits to the neonatal follow-up clinic. The things that we're looking at as a team over that time in that birth and postnatal period are, again, the NAS and the treatment for withdrawal, any health concerns, of course, at the time of birth. The mother-infant bonding and attachment is key, and the approach, again, here is to encourage breastfeeding in most cases, and that concerns about very low doses of methadone or buprenorphine that may be transmitted are outweighed by the benefits of breastfeeding. So again, I don't want to speak for the neonatal experts, but in general, as a team, that's our approach, is that we are promoting breastfeeding. Karen Shea will talk a little bit more about the safety concerns and the approach of child welfare and looking at the safe home environment for the baby. We're also looking again at family supports and whether referrals need to be made for other kinds of issues that may be affecting the home environment, such as domestic violence and mental health, and providing support for parent or parents. And the implications of toxicology results would be considered. So on an ongoing basis, follow-up services are provided by the NeoMed clinic, who continues to see the baby and their mom for up to 18 months and does conduct a developmental assessment of the baby at that time. And also, the moms are continuing to receive medicated-assisted treatment and substance abuse counseling. And they may be transferring that treatment. If they've been receiving it at the hospital during their pregnancy, they would be transferring that to another provider. And I should mention, too, that while the neonatal follow-up clinic, or the NeoMed clinic, continues to see the mom and the baby, they are also establishing a primary pediatric provider who is providing pediatric, kind of regular pediatric care to that infant during that time as well. So the things that we're looking at as a collaborative during that time are, as I said, the NAS treatment and the monitoring of that and the weaning over time, the continued engagement in substance abuse treatment, child safety and social service needs, looking at risk for relapse, which is certainly something we don't want to overlook in those few months following the initial postpartum, when there's a lot of focus on mom and baby, but then a few months later, as that support kind of isn't quite as present, that risk for relapse may increase. And so we want to make sure to attend to that. And any of our CHARM team members may add to our priority list at our monthly meeting and say, this is a patient I'm concerned about. I think she's at high risk for relapse right now because of all the things going on in her life, and so that would be a patient that we would focus on in our meeting, spend some time trying to figure out, again, what kind of supports and services need to happen at that time. Or if she has not been in contact, do we need to have somebody try and reach out to her, and who's in the best position to do that? So that collaboration can look a lot of different ways, both by the individual service providers providing treatment, but in that monthly meeting where we come together as a team, trying to figure out, by sharing information, what's the best way to provide that support that's going to ensure her continued success in treatment and, most importantly, the continued health and safety of the baby. So what makes this whole thing work? Well, first of all, again, that shared philosophy that I approached is really key, because if you don't have that, then you're not going to have each of the partners wanting to share this information. So making sure that we all are on the same boat in terms of there's a reason for sharing this, in that we know that it's the best way to make sure that the baby is safe and healthy. And the value of just coming together and sharing information can develop trust, minimize misunderstandings. It's a time saver. One of our, the neonatal nurse practitioner just very recently said to me that these team meetings are really valuable because they save time. And she was saying that just in terms of the calls made, the messages back, the waiting for return calls for all these different partners, that would take so much time. And within a few minutes, you can get that essential information about each of the patients that we're talking about. So while it is a chunk of time spent together, in the long run, it saves a lot of time from chasing information or reducing misunderstandings. We also develop an increased understanding of each other's roles, so we have a better understanding of why one of the other partners might be pursuing a certain course of action, and that really helps in providing optimal treatment for the patients in the long run. We know that sharing information is critical to providing the best care and services to the moms and the babies, and so that is a key part of making it work. If there were members of that team who felt that this doesn't work to share this information, then it wouldn't be nearly as effective. We've found over the years that we know that we can provide better care and services for the moms and the babies, and the health outcomes are better when we share information. And we've had examples of situations where, for example, a situation where child welfare was able to close a case knowing that a plan of safe care was in place, mom was doing really well, she was attending treatment, and they got updated information from that CHARM team. Everyone on the team said, agreed she's doing well, baby's doing well, and they were able to close out that child welfare case confident that everyone was on a path to doing really well. And being able to provide that information in real time is critical. We also look at, on a continual basis, systems improvement and looking at outcomes evaluation through a project with our health improvement process. So the information sharing that I've referred to is I know, elusive to many folks, and has been probably the area of biggest challenge. So just to share with you for a moment what we've come up with. The first and probably most important thing was hammering out a memorandum of understanding between all of the key players. And within the last couple of years, that has been updated as a number of additional players have come on board. So we got everyone essentially to agree to the principle that I just shared, that the information sharing is going to lead to better outcomes for these babies and for their moms. And so with that underlying philosophy, then we came up with an understanding of how that information would be shared. And key to that is that patient consent to release information. And that consent, of course, overrides 42 CFR because the patient is specifically, mom is specifically agreeing to release information. And to whom? To each of the key partners on that CHARM team. And so we came up with that process. We were worried at first, were these moms going to sign this release of information? Was this even going to work? We find that overall most do. I can't say every single one does, but most do because of that motivation to make sure that their baby is born healthy and they want to engage in the support of all of the treatment supports that they can access. And because our goal is really to provide the best care for them and for their baby. And it's to their advantage to have that important information shared. So that has worked well. It wasn't easy to get there. It took us a couple of years, but that has been really the foundation of how we share information. The other thing is that we're fortunate in Vermont law to have a provision which allows service providers to come together and share information where there are child safety concerns and to work in partnership with our child welfare agency. And so when we don't have that release of information, but we have a child safety concern under the same guidelines that would enable child welfare to get involved, we can share that, that child safety risk information as a team. A couple of other things about our information sharing is that we don't use electronic information sharing at this point. We still, as a team, there are service providers within our team that do share information electronically through the electronic health record. But as an overall team with community-based service providers, we don't have the means to do that confidentially yet. And so when we come together at that monthly team meeting, we're sharing hard copy notes. And those are client-level information, very specific to each client, those notes. I wanted to talk just a little bit about the cost because people ask about this, and those of you that are looking to have a collaboration in your community are probably going to want to know that. So most of the team provides, their services are provided, by their respective agencies. When we come together as a collaborative, that is time that that is provided in relationship to the services that they're provided. My time as a facilitator is supported by our alcohol and drug abuse program of our health department, so by public health. Some agencies can bill that time as case management or case coordination. And it comes to about 30 staff hours of the specific collaborative approach on a monthly basis. So again, we look at that as a value-added cost of collaboration. In terms of the services that are provided specifically, most women are eligible for Medicaid, and then that covers their MAT through labor and delivery and 60 days postpartum. And then many are able to receive medical care through federally qualified health centers after that. The MAT funding and care coordination is provided through an initiative of our alcohol and drug abuse programs, and that does provide ongoing substance abuse counseling through the MAT providers in partnership with community-based treatment providers. And that has been a really important development in the last couple of years. A couple of other last key things about our project that have been really helpful. We do include training and staff development. We've done some cross-training, usually pretty informally. People on the team have asked for information about different aspects, and we try and incorporate that into our team the first few minutes of each team meeting. And then the Improving Care for Opioid-Exposed Newborns project that I mentioned earlier does provide an annual, or host an annual conference on the care of infants who are opioid exposed. And they also do regular webinars for not just our whole team, but many, many service providers involved. This quality improvement project includes lots of different components, really looking at different quality outcomes. But again, one of the most important parts of this that I would like to emphasize is including a parent advisor, an incredible young woman who was a heroin addict and was somebody who came into treatment early and is now a wonderful mom of 2 healthy and wonderful kids, and has just shared her experience and the expertise she's developed with this team very generously and graciously, and has helped us all learn so much to be able to help others with this experience. It's not that we don't have ongoing challenges, that is for sure. We continue to have a significant problem with opioid abuse in Vermont, and with that, a significant number of increase in the number of patients coming in, increase in the number of child protection reports. Accessing medicated assisted treatment after delivery is a challenge. Support services on an ongoing basis is something we still struggle with because we don't continue to follow these women on a long-term basis, and so we need to make sure that they continue to get access to the many services that they need, and these are just a few of them. But on the whole, I think we are just thrilled to have been able to come together as a team to approach this collaboratively, because we know that the outcomes for the work that we've done are positive, and we continue to learn from that. The child welfare part of the work, I've kind of skipped over a lot of that, and that is a key part of our monthly meetings, is talking about the role of child welfare. I'd like to now turn it over to my colleague Karen Shea, who's going to talk about the role of child welfare on our CHARM team. So Karen?
Thanks, Sally. Again, I'm Karen Shea, and I'm the Director of Operations and Child Protection for DCF Family Services. And I'm going to share with you the history of our involvement with CHARM, and also some of the impacts CHARM has had on our current policy and practice. But a disclaimer is that I haven't sat on the CHARM team directly in a number of years. There have been several supervisors that have come after me who've sat on the CHARM team, including Beth Bolio, who's sitting in my office with me to keep me honest and make sure that I don't overstate anything or get anything wrong. But when I was involved with CHARM, I was actually the supervisor in our Burlington district office, and it was back in what I would refer to as the early days of CHARM's formation when I was participating. And Sally mentioned this before, but I don't think it could be, I think it's worth saying again, that the early days were not easy days for anyone. I think that we were really all grappling with what is this thing we're dealing with here as a group of professionals, and how can we do it the best way we possibly can. This was during a period of time in Vermont where I would say that our own education, our own experience with opioids was very much in the formative years. We experienced in the early 2000s an increase in the use of opioids, much like Nancy described. The colors across the map sort of matched our experience. And in Vermont, back in the early 2000s, we did not have access to medication-assisted treatment as an option for women or for anybody who were experiencing addiction issues with opioids. So the whole concept, of medication-assisted treatment for adults in treatment was one thing, but then on top of that, you layer the potential for there to be medication-assisted treatment or treatment with those medications for the infants, and then thinking about these moms as parents. I think that it made a lot of folks very nervous and maybe not necessarily open-minded, so to speak. So when we started to sit together and meet early on, I think there was a lot of concern about what each of our individual agendas were. So as Sally described, coming together with a shared philosophy was really very important. What was it that we all wanted to be true for these infants, and how could we try to find that common ground as opposed to really actively trying to figure out one another's agendas. And clearly being open with one another about the fact that we do, by virtue of our roles, have different agendas, that there were people sitting at the table who were substance abuse treatment, but there were people who were there as providing prenatal care, and then child welfare was involved too, and we all have our own specific area of emphasis and focus. But to the extent that we could sit together, talk about individual cases, and really try to explain ourselves so we can educate one another, it allowed us to actually build trust, and that was in large part built by creating an atmosphere where there were no real surprises, that we were trying to make sure that we didn't accidentally drop a landmine without being clear about where it was coming from, or and really trying to work through those things as we really learned one another's systems. Hold on. So as I mentioned, one of the big pieces of being together and working closely was really trying to both inform, but allowing ourselves to be informed by one another. And this happened through the case-specific dialogue. We were able to really identify where there were barriers, where there were challenges, but also where there was trends of success, things that were going really well, and building upon those pieces as well. And as we met with one another over time, I, as part of the team, was able to really hone in on what I think were key areas of challenge, things that about child welfare's practice that were very troubling to our partners and were worthy of really reconsideration and thinking about what needed to shift within our system in order to better address the needs of these children and their families. And the buckets that I kind of grouped these into were really our practices around report screening. Then the piece that I think was back in the early days challenging was really what was the focus of our intervention? Was our focus to prove that there had been prenatal substance use and to kind of catch that had happened, or was it really to be forward thinking and looking ahead and trying to address the risk that might still exist? So really, what is the focus of our intervention needed to be clarified and sorted through so that people, including our internal audience, could really understand what that work needed to look like. And then our case determination practice. I think that what we were struggling with was a lack of clarity in policy around what do we do with these cases, and what are the implications for involvement in the child welfare system for these families. So we, because one of the benefits of working in a small system is that you can make subtle shifts, and they have a big impact. And I think that the nice thing about CHARM was that we were able to take the direct learning that happened through that team and really to very quickly move it into our policies in order to adjust our interventions to be aligned with what the rest of that team was trying to accomplish. And we were hearing quite a bit about concerns about how we were screening our reports, and that we were thinking about prenatal substance use all as Nancy mentioned before, all as like one big thing, not necessarily refining it down to try to be clear about the exposure that might happen because of appropriately used medications versus versus heroin use during pregnancy. So we needed to get better about sorting, so to speak, and figuring out what were those cases that we were actually going to be intervening with and thinking and looking at as a valid allegation of that warranted our response. And so what we tried to do, and I actually think that even, it's always nice to continue to learn, and learning with people here today, I am looking at the language in this policy and realizing that we probably have some updating to do even still. In the past, when we were working on this, we wanted to try to get at the pieces around the use of illegal substances and then non-prescribed prescription medications, but I think I actually like the language that was used earlier around non-medical use of prescription drugs to be even clearer about what we mean here. And it's really, we're trying to get away from, we want it to be explicit that we're not going to accept a report for child welfare intervention if a parent is on medication-assisted treatment and they're working the recovery process that has been that they've been part of creating with a doctor and their treatment team. So those are not the cases where we want to or need to be involved. However, if there's a situation where there is continued illegal substance abuse or use of non-medical the non-medical use of prescription medication, then those are the cases we want to be involved in and should be involved in. And we also wanted to really hone in on the fact that it's during a period of time during the pregnancy too, that we were looking at the last trimester, because if a mom is using during that period of time, then it may suggest that there is a need for treatment. And so this is really an attempt to try to be proactive and to try to make sure that we're screening for those issues, and also making sure that the parent is referred to appropriate assessment and treatment that's indicated through that assessment. We also looked at other areas, and I'm not going to go through all of these word for word, but things like a positive toxicology screen for an illegal substance when the newborn is born, or NAS scoring that suggests the child had been exposed, or FASD diagnosis by the medical professional involved in the case. So we really wanted to make it clear that our role was not to be involved in all cases where there's medication-assisted treatment, but really where there is an issue that suggests that a parent is either continuing to use or that the baby was born tox positive. And when we would become involved, I think there was a lot of concern on the part of the other CHARM team members that what would it mean for the parent in the long run for child welfare to be involved, and concern about the unintended implication of that child welfare involvement might have on a parent's willingness to seek treatment. So we wanted to make it really explicit within our policy that we are not looking to substantiate child maltreatment for these cases, that that's not the basis for our involvement. Instead, the basis for our involvement is to do what we refer to as a family assessment. So I think it's subtle but important distinction that we are not involved to be fact-finding about the use during the pregnancy. That's not what we're looking to do. We may need to understand it in order to in order to make sure that we're appropriately screening and referring for assessment. But as a worker who does investigations and assessments in our system, I don't want that person out there in thinking that their role is to catch the parent having used. Instead, what they're really charged with doing is making sure that they're looking at what I refer to as the holding environment that the infant will go home to from the hospital. So doing an assessment of what is it safe enough? Is the parent able to meet the child's needs? And is there any unmet need that we need to be working to try to address to ensure that the child is safe? Another key concern that we heard again and again from our CHARM team members was really related to the when of our involvement. When we would become involved, historically, it would be after the newborn was born. So back in the early 2000s, we would not accept a report until after the baby was born. And really, I think that didn't work for any of us. It didn't work for the provider community. It didn't work for the family, and it certainly didn't work for our staff, because really what it meant was that we were dealing with a set of circumstances that were really very much, if we were not creating the crisis, we were not necessarily diffusing it by getting involved at that point. And we felt like we were really missing an opportunity to, in situations where we had a valid allegation, either the parent had continued use in the last trimester of pregnancy or was admitting that to providers, that we were missing an opportunity to really help them avoid a crisis and to help encourage treatment and help link parents to treatment before the baby was born. And ultimately, that was not only a disservice to the parent, but also to the baby that was going to be born as well. So what we did was we shifted our policy so that we now, if we get a report that is a valid allegation of that, as I mentioned before, and I gave you those examples, then we would open a family assessment up to a month before the infant's expected due date. And when we open those assessments, we're really trying to understand what is in place for treatment. If there's not any treatment that's currently in place, we're trying to create linkages to services that are indicated for the parent. We're also trying to understand, are there other unmet needs? Is there housing issues? Are there issues with domestic violence or any number of other issues that that we're all very familiar with, and trying to engage the network of providers that might be involved with the family, and also any network of informal family support that might be called upon in order to support the parent if they are entering into treatment or if they just need support of any sort after the infant's birth. And so again, I mentioned before, the assessment is really focused on the future. Can this parent successfully and safely care for the child? Is there a need for treatment? And is there a need for a referral to other services? And we are really trying to benefit from the expertise of others. So to really take information from treatment, take information from the medical community that is provided to us through the CHARM Collaborative, and also in other parts of our state where we don't have the CHARM Collaborative, other providers that can help us to sort through what the treatment plan should look like for individual parents. So I mentioned this before, that we respond to valid allegations that we receive, not as an investigation where we have to make a determination about whether or not child abuse or neglect has occurred. Instead, what we're looking at is what is the service need and what is the risk to the child. So in both our investigation track and our assessment tracks, we're completing safety instruments and we're completing risk instruments, and those are uniform across those two case types. But at the end, what we're looking for in a family assessment is whether or not there's a high or very high risk of future maltreatment. And if that determination is made that there is a high or very high risk, then we would open a case for an ongoing family support case with or without court involvement. Clearly, if there's an immediate need or if there's danger or ongoing risk that needs to be immediately addressed and brought to the court's attention, we can do that as well. But I share this because it's, the focus piece again. It's really what is it that the child welfare response is looking at. It's not necessarily historically oriented. Rather, it's really trying to make sure that we are affirmatively linking the parent with the resources that they need in order to safely care for the infant. So there are many cases that come to us before CHARM has had an opportunity to engage with the parent, and regions around the state that aren't served by CHARM. And quite frankly, the CHARM Collaborative, I think the cases that are served by CHARM are actually, we feel quite assured that there is a team of people that are working with those parents to make sure that not only are their needs being met, but that their children are being safely cared for, and that team also has a strong safety focus, that if there's any concerns whatsoever, that they're making those reports and sending those cases to us to intervene. And what we're trying to focus on at this point is really, because with CHARM, a lot of times those are actually self-identified cases. The parent will come forward and they're pregnant, and they're really wanting to make sure that they're addressing their addiction issue while they're pregnant, because they want to have a healthy infant. It's those cases that we haven't heard about through CHARM that we're really trying to improve our practice in the state at this point, and want to work to do a better job of identifying those moms and making sure that they're referred to treatment. And so to that end, we actually had the benefit over the last few years of having a regional partnership grant, and that grant, one of the parts of that was to embed substance abuse screeners in our investigation and assessment units, and those screeners would work hand in hand and go out and accompany our social workers on the point of first contact with the parent to make sure that we were really actively identifying any substance abuse issue and making warm referrals to treatment or to assessment and then to treatment. So we've had screeners in 2 of our 12 district offices, which is certainly not enough, but I'm pleased to say that we're growing that to 6 out of our 12 right now, and I think that this is an area where we'll, I think, really end up having a lot of future success in getting at these issues early and helping to connect people to the right services as soon as we can. And obviously with child welfare, it's always about safety. Safety, safety, safety. Everything we do is about safety. But I say that knowing that safety can be accomplished through things like this collaborative, that the shared philosophy is key, that and the trust that my partners in the community share that safety orientation is really important. I remember doing this work as a worker back in the early 2000s, feeling quite alone in all of this, and feeling like, I had to second guess doctors or treatment. And instead, I feel like we've shifted to a place where I think in our system that we recognize the value in one another's roles, and that it is not child welfare's role to say to a doctor, you must reduce this parent's dose or increase this parent's dose, or that this baby shouldn't be on methadone. Instead, we need to work together to pool our expertise and to make sure that we're all striving towards that shared philosophy. So, and I think we're doing that better and better, but always with room for improvement. So I will share this back, or give this back to you, Nancy.
Thank you so much, Karen and Sally, for sharing the progress that you've made, your challenges, and your successes. We appreciate that very much. Just to let folks know that there are resources on this topic that are available through the National Center on Substance Abuse and Child Welfare. That prior screen had the cover of the case study for the CHARM Collaborative, which will be emailed to you with the PowerPoint presentation from today at the close of this session, or later today you'll be receiving that email. We also recognize that we have many other resources on the National Center website, in particular a monograph on substance-exposed infants and case studies from state responses to that issue. If you're not familiar with the drug testing monograph that is available through the National Center, we want to make sure that you're familiar with that and the resources that are there for drug testing and child welfare. Also, 2 resources to highlight. One is we're putting the pieces in place for you that describes the online training that is available for both child welfare, substance abuse treatment, and court professionals. They come with free CEUs. If you haven't explored that online tutorial, we would encourage you to do that, as well as a training toolkit that is on our website, which is geared to child welfare and training about substance abuse, mental health issues, co-occurring disorders, children's mental health. So there are training materials that are available if you are in child welfare and find that you have workers that need this information. It's time for us to have a bit of time for some questions, and we note that we're just 2 minutes away from the scheduled close of the webinar. We have our email contact information. We've received many questions during the registration process and again during the webinar today. Many of them are things that we've already put resources together for, so we'll summarize sort of the major themes of the questions that we've received about screening, about the ways in which NAS is scored, and make that available to you. And so look for information from us in follow-up to this to share those resources to make sure that everyone has access to that information. With that, let me do some final thank yous to the National Center staff who helped put the webinar together, and again to our guest speakers, and to the sponsorship of the National Center on Substance Abuse and Child Welfare from the Substance Abuse and Mental Health Services Administration and the Administration for Children, Youth, and Families. We look forward to future contact with us. Please do email us if you have questions. We'd be delighted to be able to help with any of that. Thanks very much, everyone.